Hello and welcome. In this video, we'll be solving medical laboratory science professional licensure examination questions. This is actually supplementary for May 2015 for degree holders. Okay, we'll be starting with hematology. Hematology has 25 questions. Okay, it's often said that the supplementary is more challenging than the main paper. I find that to be somehow true because it requires an extra effort to actually pass the supplementary paper. So I entreat you to pay close attention to the analysis of the answers. Okay. So it says that choose the most appropriate answer only. That's the instruction for the questions. So question 1. Which of the following cells does not undertake phagocytosis? A. Neutrophils. B. Dendritic cells. C. Macrophages. D. T lymphocytes. E. B lymphocytes. The correct answer here is D. T lymphocytes. Okay. Phagocytosis is a process where cells engulf and digest larger particles. The larger particle could be a pathogen or dead cell, and by so doing, they help protect and fight against bacteria or any other harmful particle. Okay, if you take neutrophils, dendritic cells, and then macrophages, they all have phagocytic activity. They are able to phagocytose. Dendritic cells also have the function of antigen presentation. Okay, but it can also phagocytose. Then if we turn our focus to option D and option E, option D, that's T lymphocytes. T lymphocytes do not phagocytose. What they do is that they kill infected cells by programming them for apoptosis. So that's how they kill cells. They kill infected cells. Okay, then if you look at B lymphocytes actually do or not, strictly speaking, cause phagocytosis, or they do not undertake phagocytosis. So what they do is that they produce antibodies, and these antibodies can actually activate complementary to lead to the lysis of a bacteria, and so on and so forth. So strictly speaking, they also do not undertake phagocytosis. So actually D and option E are correct, but we have to just choose one answer. So we choose D, that's the T lymphocytes. Okay, question 2. It says that which of the following organs contain resident macrophages? A. Lungs. B. Liver. C. Spleen. D. Lymph nodes. And then E. All of the above. So the correct answer here is all of the above. So if you look at the lungs, for example, the macrophages in the lungs are the alveolar macrophages, and they help to clear any inhaled particle or pathogen. If you look at the liver like this, they have the Kepha cells, and then it helps to filter blood and then remove pathogens and then debris. If you look at the spleen too, in the red pulp, there are macrophages. They help to remove old red blood cells. And then if you look at the white pulp of the spleen too, they are also involved in immune response. Then if you look at lymph node, of course, they have macrophages, and then they help to filter the lymph fluid and contribute to immune response. So all these actually have resident macrophages in there. So the correct answer for number 2 is E, that's all of the above. Question 3. All myeloproliferative disorders arise from precursors of the A. Lymphoid lineage in the bone marrow. B. Myeloid lineage in the bone marrow. C. both lymphoid and myeloid lineages, D, erythroid lineage in the bone marrow, and E, none of the above. Okay, so the correct answer here is the myeloid lineage in the bone marrow. So myeloproliferative disorders are a group of blood cancers that usually are characterized by the overproduction of blood cells. So you see elevated levels of RBC, you see elevated levels of WBC and platelets, but then it doesn't, the lymphocytes are not elevated anyway, just to quickly add. Then examples of this include chronic myeloid leukemia, then we have polycythemia vera, then we have essential thrombocythemia, and then primary myelofibrosis. These are all myeloproliferative disorders. They will result in overproduction of red blood cell, and it's a cancer. So for this question, it says all of them arise from precursors of, so the answer here is the myeloid lineage. They arise from the myeloid lineage in the bone marrow. Okay. Question 4. It says that one symptom shared by all myeloproliferative disorders, with the exception of the essential thrombocytosis, is A, enlarged liver, B, leukocytosis, C, an enlarged spleen, D, an enlarged lungs, E, an enlarged heart. So the answer here is an enlarged spleen. So all the myeloproliferative disorder, if you take polycythemia vera, if you take chronic myeloid leukemia, if you take primary myelofibrosis, you would see splenomegaly. So splenomegaly, that's enlargement of the spleen, is common in these types. If you take essential thrombocytosis, for that one, you may not always see splenomegaly, but then it involves primarily elevated platelet count, but you may not always see the splenomegaly. So the correct answer for here, question 4, is an enlarged spleen. Okay. Then question 5. Question 5 says, which of the following is a primary lymphoid organ? A, fetal liver in the fetus. B, lymph nodes. C, Peyer's patches. D, spleen. And then E, mucosa associated lymphoid tissues. So the correct answer here is fetal liver in the fetus. Okay, so what do you call it? Fetal I don't even know how to start. So fetal liver in the fetus is a primary lymphoid organ, and apart from that too, another primary lymphoid organ is the bone marrow and then the thymus. So these are the primary lymphoid organ, and in the primary lymphoid organ, that is where the development and then the maturation of lymphocytes are. If you take the secondary lymphoid organs, it's a place where these lymphocytes are then activated and then proliferated for their function. But then the initial development of lymphocytes actually happen in the primary lymphoid organs. And examples are the fetal liver in the fetus, the bone marrow, and then the thymus. So the correct answer here is A. If you take lymph nodes, Peyer's patches, spleen, mucosa associated lymphoid tissues, they are all secondary lymphoid organs. Okay, so that's about that. Question 6. It says that which of the following is not used in parental testing? Okay, so A, red cell estimation. B, ABO blood group typing. C, analysis of some protein and enzymes. And then D, using human leukocyte antigen, that's HLA. Then genetic testing. So basically, more like a paternity test. It's asking which of the following is not used. So the answer here is red cell estimation. If you do a red cell count, it's in no way actually related to the paternity of a child. But if you take the other options, let's say option B, ABO blood grouping, so this can actually be used to determine the possible parentage of a child by comparing the blood group of the parent to that of the child. It's very possible. It will give you the possibilities of parentage. Then if you look at analysis of some proteins and enzymes, so that is also viable. So in some cases we could test for specific inherited traits and conditions that can help to determine parentage by assaying for some of these proteins and enzymes. Then if you take option D, that's human leukocyte antigen, this one too is a very, very good and in fact precise parentage testing, and it can even, or it's even used to assess the compatibility for organ transplantation. So when there is transplantation, it's also used. So this one, HLA antigens, is also very important in determining parentage. Then if you look at genetics too, yes, that's even the king of all. That's where we do the DNA profiling. So that one can also be used to determine parentage. But if you take option A, red cell estimation, if you do an RBC, you cannot. It just tells you the count of red blood cells. That one cannot be used for parental testing. So the correct answer here is A. Okay. So question 7. It says that in the examination of red blood cell morphology, the abnormal erythrocytes differ from normal erythrocytes in their A, shape only, B, size only, C, color only, D, all of the above, E, none of the above. So the correct answer here is all of the above. So if you're examining let's say a blood preparation, let's say a film comment, and then you're looking at the red blood cells, the normal one versus the abnormal one of the features that you use to distinguish them is of course their shape. Through the shape, for example, for a normal looking red cell, you would see the typical biconcave disc shape. But then if it's abnormal, let's say in the case of sickle cell, you see that the shape is different. You may sickle. So the shape is a very important feature in distinguishing between normal and then abnormal erythrocytes. Then if you take the size too, the size too is very important, because sometimes you could see macrocytic cells, and then you could also see microcytic cell as well as the normal cell. So the macrocytic are the larger ones, then microcytic are smaller cells. Then we have normocytic, which are the normal cell size. So cell size can also be used to distinguish between the normal and then the abnormal one. Then if you take color too is a very important parameter here. Some of them, based on their staining characteristics, some of them will be hypochromic. Some too will be hyperchromic, where they will take much of the stain, and it's all one way or the other related to their hemoglobin content. So color too is very much used. So the correct answer, or the correct option here, is D. That's all of them. So all these three above here are very useful in distinguishing red cell morphology. Okay. Then question 8. It says that which of the following specimen type is not used in cytogenic testing? So A, venous blood or cord blood. B, bone marrow or tissue or tumor tissue, then seminal fluid, then D, product of conception and fetal tissue, then E, skin biopsy. So cytogenic testing basically is basically involves analyzing chromosomes in a cell from various tissues for diagnosis of genetic disorders, or for detecting chromosomal abnormalities, or for cancer. So we take some of these tissues and then we look at their chromosome to detect any genetic disorder or cancer. So the question is asking which of these specimen is not used. If we take venous blood or cord blood, of course we can analyze the chromosome in peripheral blood, lymphocytes, or even cord blood cells for that purpose. Then if you take bone marrow and tissue, tumor tissue, that one too can be used. So you can study the chromosomal abnormalities in hematological malignancies or tumors. So that one too applies here. Then if you take option C here, seminal fluid. So in seminal fluid, we typically do not assay seminal fluid for that purpose or in cytogenic testing. So our answer here will be seminal fluid. If you take option D, products of conception of fetal tissue, that one too is very much used. You can prenatally test for genetic abnormalities when during pregnancy or even after pregnancies. You could take some of the fetal tissues or the products of conception and then actually test them for any case of genetic disorder or any cancer or any chromosomal abnormality. So products of conception and then fetal tissues too are very much used. Then if you look at the option E, so it's very important. It says skin biopsies. That one too is very important. You can actually also use you can take skin biopsies and then analyze them for any genetic disorder or cancers that are affecting the skin. So of all these options, the option that we cannot use here is seminal fluid. Okay, so question 9 says which of the following component measurement is not part of full blood count test? So A, RBC count, B, hematocrit, C, platelet function test, D, WBC and differential count, then E is platelet count. So the correct answer here is platelet function test. So you would not see that in a typical full blood count. Okay, so you see of course the RBC count, which measures the red blood cells, then the hematocrit, which is the percent volume of the red blood cells, then of course you see the WBC and the differentials, and then the platelet count. But platelet function is not part of a full blood count test. Okay, question 10. It reads that anemia is generally considered when hemoglobin concentration falls below A, 11 gram per deciliter for pregnant women, B, 12 gram per deciliter for pregnant women, C, 15 gram per deciliter for men, and D, 14 gram per deciliter for men, E, 13 gram per deciliter for non-pregnant women. The correct answer here is 11 gram per deciliter for pregnant women. So that's the correct answer here. Okay, let's move to question 11. Question 11 says in intravascular hemolysis, the Hb released into the blood is immediately bound by which of the following proteins for clearance in the liver? So the options are A, hemojuvelin, then B, hemosiderin, then C, haptoglobin, D, myoglobin, and then E, stecoglobin. The correct answer here is C, haptoglobin. So haptoglobin is a protein, and then it binds to free hemoglobin in the bloodstream. So whenever there is a breakdown of the red blood cell for any reason, and then the hemoglobin is released, they are bound to this protein that we call haptoglobin, and then this binding prevents the loss of iron through the kidney. So it actually moves them to the liver for the liver to do that work. If not, that you lose most of these through the kidneys, which is undesirable. Okay, so the correct answer here is C, haptoglobins. Okay, question 12. In autoimmune hemolytic anemia, the antigen antibody reaction are dependent on the following, except A, class of antibody, B, number and spacing of antigenic sites on cell, C, unavailability of complement, D, environmental temperature, and then E, functional status of reticuloendothelial system. The correct answer here is C, unavailability of complement. Okay, so that's our correct answer here. If you look at it's a hemolytic anemia, autoimmune hemolytic anemia, where like there is self-destruction of your cells. So the question is asking that the antigen antibody reaction depends on which of these, except. So if you look at the class of the antibody, that's option A, is very important. Whether it's IgG or IgM really influences the hemolysis process. Then if you look at the number and spacing of the antigenic site, yes, that also really has an influence, because the density and the arrangement of the antigens on the red cell surface can impact how effectively antibodies bind, and then they cause the hemolysis. Then if you look at option D, environmental temperature. So in case of cold agglutinin disease, for example, the temperature can influence the binding of antibody to the red blood cell. And then if you look at the functional status of the reticuloendothelial system, too, that also counts here. Because the system plays a crucial role in clearance of the antibody-coated red blood cells. So it plays a crucial role here. So the option here that will not play a role here is the unavailability of complement, which is C. Okay, so that's our answer for question 12. Now, question 13, it says, which of the following is not used to treat cold agglutinin disease? A, folic acid supplementation, B, cytotoxic drugs, C, B, interferons, D, plasmapheresis, and then E, rituximab. Okay, so the correct answer here is beta interferon. Okay, so cold agglutinin disease is a type of autoimmune hemolytic disease, where the body's immune system produces antibodies that cause red blood cells to agglutinate, or if you want, clamp together in lower temperatures. So in lower temperatures, you see that for those who have this disease, the red blood cells will be clamping together, and that's very, very undesirable. Very, very undesirable. And so when you get to the hospital, how do we treat it? So they could use folic acid supplementation, which helps to support the red cell production, as you know, the very function of folic acid. Then you could also use cytotoxic drugs. This is used to suppress the immune system and then reduce the antibody production, and that also helps. If you take option D, plasmapheresis, another excellent way, it removes the antibodies from the blood, and then it can help to manage severe cases. Very, 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 very important. Then if you look at the option E, the rituximab, that's a monoclonal antibody that targets B cells, which produce the antibody responsible for the hemolysis. So this molecular, it will target the guy who is producing the antibody that is responsible for this so that's one way of treating them. But if you look at option C, beta interferon, so this is typically not used in the treatment of cold agglutinin disease. So we don't use that one here. So that's the answer for question 30. Question 14. In autoimmune hemolytic disease, splenectomy does the following. So A, it acts as a second line of treatment. B, it has multiple benefits. C, it removes sites of hemolysis. D, it decreases antibody production. And then E, all of the above. Okay, so the correct answer here is all of the above. So one of the interventions we do for autoimmune hemolytic anemia is splenectomy, and the question is asking, so what's the benefits of the splenectomy? So the splenectomy is where we surgically remove the spleen. We surgically remove the spleen, and this typically is done when first line treatment like the use of corticosteroids are not effective. So we treat you with corticosteroids. If they are not effective, then we do something more invasive. That's the splenectomy, where we remove the spleen. So A, it acts as a second line of treatment. That's very true. When the first line of treatment has failed or it's not very effective. Then B is saying that it has multiple benefits. That's very true, because it reduces the destruction of the red blood cells by when the spleen has been removed, which is the major site for red blood cell the destruction. Good. Then it removes the site of hemolysis. That's also related to the other and the multiple benefits. So the spleen is a major organ involved in the phagocytosis of the antibody-coated red blood cells. So when you remove it, a sense of remove that site where the hemolysis is happening. So that really helps. Then D, it decreases antibody production. So when you remove the spleen or when you do the splenectomy, it kind of reduce the overall antibody levels and then the production, so that the initial amount that will actually do the destruction is in one way or the other reduced. So all these benefits will actually be experienced when you do a splenectomy. So the answer for question 14 is E. Question 15 says, which of the following statements about the H antigen is true? So the options are A, the H antigen is not such an essential precursor to the AB or blood group antigens. B, the H locus is located on chromosome 9. Then C, the H antigen is a carbohydrate sequence with carbohydrate linked mainly to proteins. Then D, the H antigen contains 6 exons that spanned more than 5 kilobases of genetic DNA. Then E, all of the above. So the correct answer here is B, the H locus is located on chromosome 9. Okay, so let's look at the options one by one. So the first one is saying that the H antigen is not such an essential precursor to the ABO blood group's antigen. So this is incorrect, because the H antigen is indeed an essential precursor to the ABO blood group antigen. The ABO blood group antigen are actually derived from the H antigens by the addition of a specific sugar residue. So without the H antigen, the A and then the B antigen cannot even be formed. So this first statement is actually incorrect. You need the H antigen, they are the precursors. Then option B, the H locus is located on chromosome 9. That's a factual statement about H antigen, so that's very true. So that's our answer for here. Then if you look at option C, The H antigen is a carbohydrate sequence with carbohydrate linked mainly to proteins. That is incorrect. The H antigen is a carbohydrate sequence but is primarily linked to lipids and not proteins. Yes, it's primarily linked to lipids and not proteins. If you look at option D, it says that the H antigen contains 6 exons that span more than 5 kilobases of genetic DNA. This one too is incorrect, because the H antigen itself is a carbohydrate structure and its biosynthesis is influenced by the H gene, which does not span 5 kilobases of genetic DNA or even contain 6 exons. Okay, so that's about that. So the correct answer here is B. Question 16 says, which of the following statements about the Lewis antigen system is false? A. Lewis antigen are expressed on the surface of the endothelium. B. Lewis blood group is a minor blood group that relates to salivary secretory status. Then C. Salivary ABH secretor determination is based on testing of your blood group antigens in your saliva. Then D. Finding your Lewis blood group will tell your ABH secretor status irrespective of your blood group. Then E. Most ABH secretors have a Lewis group of the LEA- and LED+. So the correct answer here is Lewis antigens are expressed on the surface of the endothelium. So this statement is false, and that will be a correct answer for number 16. So let's just quickly analyze option A. So says option A, Lewis antigens are expressed on the surface of the endothelium. So this is false. Lewis antigens are not typically expressed on the surface of the endothelial cells. They are primarily found on the red blood cells and in secretions like the saliva, but not on the endothelial cells. So this statement is false. If you look at option B, it says that the Lewis blood group is a minor blood group that relates to salivary secretory status. So this is very true. The Lewis blood group system is indeed a minor blood group, and its expression is influenced by the secretor status. That is, whether or not a person secretes the ABH antigen in body fluids. Okay, so that's about that one. Then C, it says salivary ABH secretor determination is based on testing for your blood group antigen in your saliva. Very true. So salivary secretor status is determined by testing for the presence of ABH antigen in saliva. Okay, then if you look at option D, it says that finding your Lewis blood group will tell your ABH secretor status irrespective of your blood group. This one too is true. So the Lewis blood group status can provide information about your secretor status because it's closely related to the presence or the absence of ABH antigen in secretions. Then the option E too is true. So most people who are secretors, that is, have the ability to secrete the ABH antigen into body fluids, have the Lewis phenotype of LEA- and LEB+ or positive. Okay, so that's about that for question 16. Question 17, it says that the following are true about reticulocytes. A, they are young enucleated red cells which retain RNA. B, they are stainable by special stains. C, they stain well by Romanowski stains. D, they are young nucleated red cells containing remnants of DNA. Then D, they decrease in number following acute hemorrhage. So the correct answer here is they are stainable by special stains. Okay, let's look at our options one by one. A is saying that they are young enucleated red cells which retain the retain their RNA. So this statement is partially correct and a little misleading. So reticulocyte, of course, they are young red blood cells that are not completely enucleated. They still retain their residual RNA, but they do not contain a nucleus. Yeah, so that's about that. Okay, then if you look at option B, they are stainable by special stains. That is very true. Reticulocytes can be identified by using special stains such as methylene blue or a supervital stain that highlight the residual RNA. Then if you take option C, it says they stain well by Romanowski stain. Actually, they can stain with you can stain reticulocyte with Romanowski stain like rice stain or Jamesa. So this one is commonly done to visualize reticulocyte, although the special stains do a better job. So option C2 is also correct, but then we are choosing option B over C because special stain will do a better job than a Romanowski stain, and then the answer is saying that they stain well by Romanowski stain. So because of the well that they are putting here, then we put a sense of comparison between special stain and Romanowski, and special stain do a better job. So we choose option B as our answer. Then D says that they are young non-nucleated red cells containing remnants of DNA. So this one too is incorrect. So they do not contain DNA, but then they retain their RNA. Okay. Then they decrease in number following acute hemorrhage. This statement too is incorrect because following acute hemorrhage, reticulocyte actually increases as the bone marrow responds to the loss of the red blood cells. So that's what actually happens. Okay, so that's about that. Question 18. It says that the earliest recognizable granulocyte precursors are A. Myelocytes, B. Promyelocytes, C. Metamyelocytes, D. Blast cells, and then E. Megakaryocytes. So the correct answer here is promyelocytes. Promyelocytes. Okay. Question 19. It says that in megaloblastic anemia, A. The blood film shows oval macrocytes and neutrophil left shift. B. The underlying cause of the anemia is unknown. C. There is significant decrease in immune cell volume. Then D. Pancytopenia is rare in this condition. Then E. The most widely used screening tests for the deficiencies are the serum vitamin B12 and folate assays. Okay, so the correct answer for question 19 is the most widely used screening tests for the deficiencies are serum vitamin B12 and then folate acid. Okay, so let's go through our answers one by one. Option A, it says that blood film shows oval macrocytes and neutrophil left shift. So this option is partially correct. Of course, the blood film will, in megaloblastic anemia, typically shows oval macrocyte, that's enlarged RBCs, and then you would also see additionally to that hypersegmented neutrophils, but not a left shift. A left shift refers to an increase in the immature neutrophils, which is common in the other types of anemia or infection. But in megaloblastic anemia, we don't see that. We rather see hypersegmented neutrophils. Okay. Then if you look at option B, it says that the underlying cause of the anemia is unknown. That is also incorrect. Megaloblastic anemia is often due to a deficiency of vitamin B12 or folate. So that one is well established. So that can be our answer. Then if you look at option C, there is significant decrease in mean cell volume. This one too is incorrect. In megaloblastic anemia, the mean cell volume is usually increased and not decreased. due to the presence of the larger RBC. Okay. Then option D says that pancytopenia is rare in this condition. This one too is incorrect, because pancytopenia is where there's reduction in the red blood cells, white blood cells, and then the platelets, and this can be seen in megaloblastic anemia due to the impaired production of all the red blood cells. So in the megaloblastic anemia, you actually see these things because the production of the cells has been affected. So that's about that. So it's not rare, it's actually something that will actually happen. So that can be an answer. Then option E says the most widely used screening test for a deficiency are serum vitamin B12 and folic acid. That's very, very, very true and very, very correct. So that's our answer for question 19. Okay, question 20. It says that the human hemoglobin A, hemoglobin F has a lower oxygen affinity than hemoglobin A. Then B, fetal hemoglobin, that's hemoglobin F, is present from early through late fetal life till after birth. Then C, a complete switch of hemoglobin F to normal hemoglobin occurs at the first month in the neonatal period. Then D, hemoglobin A2 is replaced by adult hemoglobin A sometime after birth. Then E, low levels of hemoglobin F and hemoglobin A2 are present in normal adults. So the correct answer here is B, fetal hemoglobin F is present from early through late fetal life till after birth. If you look at the options, option A is saying that hemoglobin F has a lower oxygen affinity than hemoglobin A. This is incorrect, because fetal hemoglobin actually has a higher affinity for oxygen compared to adult hemoglobin, and this higher affinity is what helps the hemoglobin X to extract oxygen from maternal blood across the placenta more effectively. So this statement is incorrect. Then if you look at option B, which is our answer, fetal hemoglobin, that's hemoglobin F, is present from early through late fetal life till after birth. That's correct, because hemoglobin F is present throughout the fetal development, and then it continues to be present in the newborn period, though its levels decrease as the infant grows. Okay, if you look at option C, it says that a complete switch of hemoglobin F to normal adult hemoglobin occurs at the first month in the neonatal period. This is incorrect. So while the transition from hemoglobin F to hemoglobin A starts soon after birth, a complete switch typically occurs over the first 6 months to 1 year of the life, and it's not within 1 month. So that answer is incorrect. Then if you look at option D, it says that hemoglobin A2 is replaced by adult hemoglobin A sometime after birth. This one too is incorrect. Hemoglobin A2 is a normal component of adult hemoglobin, and it's not replaced by hemoglobin A. So you see hemoglobin A2 present alongside hemoglobin A, but typically they are in small amounts in the adult. Then if you take option E, it says low levels of hemoglobin F and A2 are present in normal adults. So this statement is correct in a sense, because while hemoglobin F levels are low in adults, trace amounts can still be detected. Trace amount of them can still be. So hemoglobin A2 is also normally present in small amounts in adults. So if you look at the E well, A2 normally it will be there. F is what should actually be converted to the A, but still you will see some trace amounts there, so making this answer to be correct. But between the E option and then the B, we will go with the B option. B2 is correct. It's a correct statement because trace amount of them will be present. Okay, but then we'll stick with B as our answer. Okay, question 21, it says glucose 6-phosphate dehydrogenase, that's GCSPD deficiency. A is a sex-linked and affects males predominantly. B is sex-linked and affects females predominantly. C, primaquine is the most recommended antimalarial for patients with GCSPD deficiency. Then D is a red cell membrane defect. Then E causes hemolytic response in hematinics. The correct answer here is A, is sex-linked and affects males predominantly. So if you look at our options, option A, which is our answer, we're saying that GCSPD is an X-linked recessive genetic disorder, which means that it affects males more frequently because the males have only one X chromosome. If you take the female counterparts, they have 2 X chromosomes, and so if one chromosome is affected, the other one is available to actually produce the enzyme so that nothing will actually happen. And so it's the males who have just one X chromosomes who really are affected the most. Okay, if you take, so that's about option B. If you take option C, which is primaquine, it says that primaquine is the most recommended antimalarial for patients with GCSPD. This is so incorrect. This is so incorrect because primaquine can actually cause severe hemolysis in individuals with GCSPD. So it's a not. It's a not. Then D is saying that it's a red cell membrane defect. So this one too is very incorrect. It's not correct. GCSPD is actually an enzyme defect. It's an enzyme defect. Then E is saying that causes hemolytic response to hematinics. So this one too is incorrect. Hemolytic response occurs when there is oxidative stress, and not typically from hematinics, which are basically iron supplements. Okay, so that's about question 21. The answer is A. Then question 22, it says that the usual peripheral blood findings in chronic myeloid leukemia at diagnosis include the following except A, pancytopenia, B, raised white blood cell count, that's 30 to 40 micromole, 30 to 400 microliter cells per microliter. Then C, granulocyte at all stages of development. Then D, increased number of basophils and eosinophils. And then E, blast cells of up to 10%. So the correct answer here is pancytopenia. So it's obvious. So in chronic myeloid leukemia, we are expecting most of the cells to be in large numbers. So all these conditions will actually happen except pancytopenia, which is actually saying that there will be a reduction in the red cell and the white and the platelets, which is in contrast to the condition. So that will be the exception here. That's pancytopenia. In CML, there will be raised WBC count, and then there will be granulocytes in the peripheral blood at all stages or at various stages of the maturation, from the myeloblast to the mature granulocyte. Then there will be, like option B, elevated basophils and eosinophils. Then option C, there will be up to about 10% blast cells that can be observed in the peripheral blood smear during the chronic phase of CML. Okay, so the correct answer here is A, pancytopenia, which is in contrast to chronic myeloid leukemia. Question 23. It says a routine investigation to confirm a case of suspected chronic myeloid leukemia. A. We'll do a full blood count only. B. We'll do a full blood count including GCPD screening. C. We'll do a full blood count including blood film picture. D. We'll do a full blood count including WBC differentials. And E. We'll do a full blood count including coagulation screening. The correct answer here is of course C. Full blood count including blood film picture, which gives us more information. If you do only a full blood count, this is a general diagnosis leukemia, but it alone will not provide enough information to confirm the diagnosis, so you need the blood film too. Then option B, JSSP is not really useful here. Option C is our answer. Of course, the blood film is needed to provide critical information about the presence of granulocytes at various stages of the maturation, and can also show the characteristic features of chronic myeloid leukemia, such as the increased basophils and then the eosinophils, what we just spoke about. Then if you take option D, the white cells differentials, white cell count differentials is part of the FVC. It's useful, of course, but it alone will not provide a complete picture. Then option E, coagulation screening is not typically necessary in the diagnosis of chronic myeloid leukemia. Okay, so the correct answer here is C, full blood count including blood film picture. Then question 24, it says that platelets A produced predominantly by the lymphoid megakaryocytes, then its production is stimulated by unknown cytokines. C, their normal lifespan is 7 to 10 weeks. D, the normal platelet count for all age group is 150 to 450 microliters. Then giant granular platelets in peripheral blood film is seen in Megaloblastic anomaly. So the correct answer here is E. Giant granular platelets in peripheral blood film is seen in Megaloblastic anomaly. If you look at our options, like option A, which reads produced predominantly by the lymphoid megakaryocytes, this is incorrect because platelets are produced by the myeloid megakaryocytes. Okay, if you look at option B, its production is stimulated by unknown cytokines. That's also not true. We know that platelets are stimulated by thrombopoietin, so which is a known cytokine that regulates karyocyte proliferation and then platelet production. Okay, if you look at options, it says their normal lifespan is 7 to 10 weeks. This is also incorrect. Their normal lifespan of platelets is 7 to 10 days, not weeks. So that's about that one. Then option D says the normal platelet count for all ages is 150 to 450 microliters. Sorry. So this is generally correct, but then there are certain slight variations for different ages, so that's why we are not accepting this answer. That's why we are not accepting this answer. Okay, so then option E is our answer. So in Megaloblastic anomaly, we will see this characteristic presence of giant platelets and the presence of dolly bodies in neutrophils. So that's our answer for this option for this question 24. Okay, Then our last question 25, says blood sample in sequestering if you want ethylene diamine tetraacetate, that's EDTA, anticoagulant tested by an automated hematology analyzer. Provide the following except A, hemoglobin concentration, hematocrit, red cell indices. Then B, white cell count and differential. C, enumerate immature red cells or nucleated red cells. Then D, reticulocyte count, and then E, platelet count and size. So the correct answer here is enumerate immature or red cells. So typical FBC will actually provide you with like the option A, the hemoglobin concentration, of course your hematocrit, and then your red blood cells, and other indices like MCV, MCH, MCHC. Then of course the white cells and differential also will be there. Then immatured nucleated red cells, those ones will not be there. So those ones are like, let's say, blood cells like promyeloblasts. Those ones will not be there. Full blood count does not actually show those things. You need a special test or a manual review of a smear to typically identify some of these nucleated red cells. Then of course there are option D, like reticulocytes. Yes, they are modern automated analyzers that can actually supply the reticulocyte count. Then option E, it says the platelet count and size. Every full blood count machine will be able to do that for you. Okay, so that's about that for hematology. So watch out for the part 2. Thank you.